Good morning. Welcome back to Journal Watch of Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. We all know the efficacy of beta blockers following myocardial infarction. And the current recommendation is that beta blocker should be given to those who are having myocardial infarction with ejection fraction less than normal, especially less than 40%, or the heart failure. The role of beta blocker in those with a normal ejection fraction or ejection fraction more than 50% is not well studied. The efficacy of beta blocker following myocardial infarction was done in those days where the modern treatment was not available, like that of PCI, double antiplatelets, renin-angiotensin blockers, and high intensity statin. Today I'll be discussing on the evidence for what is the evidence or what is the clinical usefulness of giving beta blocker to those with myocardial infarction and ejection fraction more than 50%. The article came in New England Journal of Medicine. So this is the article that came in New England Journal of Medicine. Beta blockers after myocardial infarction and preserved ejection fraction. Published in April 7, 2024. So it's a recent article. So as mentioned, beta blocker usage is a mandatory thing in myocardial infarction. We go to the background. The historical context, most studies showing beta blocker benefits in myocardial infarction were conducted before the modern interventions. I have mentioned about the PCI, RAS blockers, double antiplatelets, etc. Advancement in treatment questions the necessity of long-term beta blocker for myocardial infarction, especially those with the preserved ejection fraction. That is more than 50% ejection fraction. One word regarding ejection fraction. Ejection fraction is stroke volume divided by end diastolic volume into 100. That is, the amount of blood that is ejected out during each contraction is the stroke volume divided by the end diastolic volume, that is the volume of blood inside the ventricles. So how will you calculate? Stroke volume is the end diastolic volume minus end systolic volume. That is the difference between the end diastolic volume minus the volume which is at the end of systole, divided by the volume of blood in the left ventricle at end diastole. That is ventricular filling. This is how you calculate. So when this ejection fraction is less than 50%, we call it as a reduced ejection fraction. More than 50% or 0.5 is normal. So in this study design is a open label randomized trial. Parallel groups are there. There was a location 45 centers across Sweden, Estonia, New Zealand. What was the universe? Acute myocardial infarction patients with ejection fraction more than 50%. The intervention, long-term beta blockers. The beta blockers that were given were metoprolol or bisoprolol versus no beta blockers. What is the primary endpoint? All-cause mortality or new myocardial infarction. So that is whether the patients are developing the new myocardial infarction or all the causes for mortality. Methods. The total number of patients were significant, 5020. The study was done for a period from 2017 to 2023. Median follow-up was for 3.5 years. Primary endpoint, as mentioned, death or new myocardial infarction. The secondary endpoints were cardiovascular death, recurrent myocardial infarction, hospitalization or atrial fibrillation, heart failure or stroke. So these were the secondary outcome. So what was the result? Primary endpoint 7.9% in beta blocker group, 8.3% in non-beta blocker group. So conclusion was no statistically significant difference between those who were on beta blocker and who were not on beta blocker. Coming to the mortality, 3.9% in beta blocker, 4.1% in non-beta blocker. The secondary outcome, CV death 1.5 versus 1.3%. New myocardial infarction 4.5 for those on beta blocker, 4.7% for those on not on beta blocker. Hospitalization or atrial fibrillation, heart failure or stroke, there was no significant difference. The endpoint safety, bradycardia, AV block, 3.4% in beta blocker, 3.2% in non-beta blocker. The COPD asthma, 0.6% in both groups. Stroke 1.4 versus 1.8. So there was no major safety concerns on using or not using beta blocker. So what's the conclusion? The primary conclusion is that long-term beta blocker therapy did not significantly reduce death or myocardial infarction in patients with preserved ejection fraction post-acute MI. What is the clinical implication? Routine beta blocker usage in acute myocardial infarction with preserved ejection fraction may not be necessary. Let us look into the current guidelines. The AHA, ACC guideline, beta blockers are recommended in acute myocardial infarction, particularly with those with reduced ejection fraction or heart failure. So remember, beta blocker should be given if the ejection fraction is reduced. The European Society suggests reassessment after 3 years in stable patients with preserved ejection fraction. So the recommendation at present is for those with reduced ejection fraction, less than 40%, beta blocker should be continued indefinitely. And those with preserved ejection fraction, after 3 years, if the patients are stable, you may reassess the need for beta blocker. So take home message. Beta blocker benefit patients with myocardial infarction and reduced ejection fraction. And in preserved ejection fraction, long-term use may not be necessary. I'm not telling that it can be discontinued. It should be reassessed. Reassess the need for beta blockers in stable patients with myocardial infarction and preserved ejection fraction after 3 years. So further studies are there. In next session I will discuss another study where the use of beta blocker, beneficial effect of beta blockers were described. So at present, after long-term therapy after 3 years, to be reassessed and then continue or discontinue depending upon the situation.